Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Hello and welcome back to the Low Carb MD podcast. Tro, we're excited today. Tro and I are like little kids now. We're excited again about life because we have a great scientist here to educate us and educate you also.
Yeah, listen, I'm excited. Somebody whose work I've been following for a number of years, certainly an inspiration. I've seen him on various podcasts. I think even he was on Dr. Hyman's podcast like just last week or this week before. I got to catch that episode. I am just so happy to have Dr. Campbell here. I'm actually going to have the honor of meeting him in less than a month's time, so I'm excited about that. He has a Ph.D. in global health from the University of Edinburgh. He, I believe, did the first trial with interventional trial with ketogenic diets for bipolar, if I'm not mistaken. And you can correct me if I'm wrong with that. Dr. Campbell, awesome to have you here. Excited to have you here. I think it is the first interventional trial, right, for keto for bipolar?
It's a real honor to be here. I'm a huge fan of the show, huge fan of your work. So to put the record, I think Shivani Sethi started the first trial in pilot trial in bipolar disorder for ketogenic diet, and I'm very happy to have done the first one on our side of the pond. It was a pilot study of a ketogenic diet for bipolar, but there's many. Decades of clinicians before that publishing case series, case studies, working with patients. So it's a huge effort from a lot of people to get towards this. There was Chris Palmer's been publishing case studies for like probably 15 years in the literature of his patients. Eric Kossoff, Malik, others. There's a whole. With any kind of like given field, is you kind of tend to think of certain studies, but actually there's always a long history of people that have struggled to like bring attention to this area of research, and I always try to honor that in the talks we give. And certainly a lot of clinicians have been using this. Georgia Eads for very long periods of time. So it's a huge team effort to get to this far.
You think he's too humble for this podcast? We're gonna have to shut it down here.
Yeah, no doubt. You've done some great work. I've looked at your study because I remember Chris Palmer, when I first heard about him, I was like, yeah, this is a stretch. Schizophrenia scares all of us primary care doctors. It's a scary thing. And now when I have a schizophrenic patient come in, I was like, you know what? We can help you. There's stuff we can do. Let's look at these different options because the drugs haven't been working for you. I just got a new patient. I want to cry because his family is so kind and so nice, and they're trying everything to help this guy. And no one ever talked nutrition at all to them, ever. It's never come up in conversation, and his brother happened to go into low carb and keto, and he's seen some of your work and some of the work that's been done. So just to provide hope for the family that there is a chance that we can help people. And so your work is incredibly important, especially now because we're seeing a pandemic of depression, anxiety, mental health issues, violence in our community. It's like, what do we do? We're helpless against it.
Yeah, I come from a family where mental health has been a major battle for my mother had a severe neurological illness, like an aneurysm, and I guess my interest came through this. I lived with a mother who was a completely different person for 10 years than what I grew up with after having a brain aneurysm. And it really shows you how much of the brain, how much the brain function is related to your personality and the way you act in the world and the way you show up in the world. And so, for 10 years, me and my father looked after her when she was couldn't function, completely different personality. And it kind of put me down this road of are we just a bunch of chemicals? Is this just what we are? Are we just a bunch of neurochemicals? And if you change those or disrupt them, does your whole personality change? To me, it feels like there's something kind of deeper to human nature than just brain chemicals and how they're modulated. But at the same time, living with bipolar, that was kind of what I was told about my own brain is you have a neurochemical imbalance, and this defines who you are. And I was like, it doesn't feel like that. It feels like there's something more to being human than just there's chemicals in the brain. I actually wrote a song about it when I was way a long time ago. I used to write music, and I wrote this song called Oxytocin, and I was trying to say, like, how can you try and define like a human emotion or a human experience as a chemical? It doesn't add up to me, and it made me kind of question what I was being told about mental illness, because I felt like I could see with my mother, like what she was going through, that there's still something that was, she was still there even though all of her function was disrupted. And I eventually found this analogy someone told me, that it's like the brain is like a piano and you're like the player of that piano, and you can have the piano be completely out of tune and it's going to sound really disharmonious, but there's still you behind that piano, and the instrument that you're kind of expressing through is broken. And that helped me to like understand that idea of how my mother could be so different with her brain being disrupted like that. And it also made me think about as a sort of deeper explanation than this neurochemical imbalance for mental health. It made me consider maybe there's other things going on here, and we can talk about that in more detail.
Yeah, it's near and dear to my heart. My mom recently passed. She had bipolar her whole life, and it was such an area of shame for her. And then, when she was happy, we're like, oh, is she too happy? It was one of those hard things. As a doc, I would take the forefront. She'd get really mad when I said, Mom, are you taking your meds okay? And, but the craziest thing is she'd always cycle during the holidays, and my birthday happened to be during the holidays. So every time I was like, uh-oh, here it comes again. And, there's definitely a correlation when she ate processed food, sugary food, all the holiday treats and all that stuff, boom, her mental functioning would worsen. And then January would come and she'd try to get back into shape and exercise, and then she was stable for the rest of the year. And so these kind of things, where you start seeing that, I go, gosh, how much of a contribution is and increased stress at the holidays, and maybe not sleeping and not exercising and eating poorly, and you go, how much does that affect our mental health?
Can I ask, when she had, if you don't mind me asking, when she had episodes, was it, when you say the holidays, what time of year do you mean?
Oh, really? Like after Thanksgiving. It was always like after Thanksgiving, Christmas. Like my birthday's December 22nd. So it was like every year, like, uh-oh, I got to take care of Mom on my birthday. It was rough.
She would have like the depressions during the winter, or?
No, she'd have the depression more in like after she came down from the high of the holiday. So maybe January, February, she'd be down. And then March, April, she stabilized again. Yeah.
Okay, that's interesting. Yeah, like there's definitely this kind of seasonal variation to bipolar that I've certainly noticed, and it's something that I'm really interested in because it's related to metabolic function, I think. But yeah, like having a family member with bipolar is tough because it's I mean, if you have a family member with like many other chronic conditions, there's at least like a kind of clear treatment plan, and you kind of know there's a route you're going to go down, and there's this percentage chance, or there's this likelihood they're going to be okay. But with mental illness, you really feel like you're rolling the dice, and I kind of that gives me a lot of sympathy for people that go through these things, because it's not, you don't get the level of reassurance you do with other kind of chronic conditions. But in terms of like having like different times a year where things are harder, that's a huge battle in bipolar. It's something I've been interested in recently. I've just published a paper called Metabolic Plasticity about this in Nature Molecular Psychiatry. And like certain times a year, you mentioned Christmas and the kind of Thanksgiving, and many people, their symptoms come on around these times a year, and it is related to the changing photoperiods. So if you look at like a review of when people get hospitalized with bipolar, they tend to get hospitalized in the spring and in the autumn. I guess autumn's around Thanksgiving, I think. And then in the winter, they get depression, like around Christmas time. That can be when, for many people, depression is worse, although some people also get mania. So it's interesting to me, like, why that happens. And did you notice, did you feel it was related to the sugar consumption and things around Christmas time?
That's the only thing I correlate to. Just knowing what I know now, I'm like, I wonder how much was that, or increased stress. Like she got diagnosed after she went through a bad divorce with my dad, and then the bipolar really kicked in. She kind of always had these little tendencies, but this lady's like the sweetest person on earth, but when she's manic, you're like, oh no.
Yeah.
It's like she'll tell people what she thought, and like even if it was accurate or not accurate, and you go, wow, it's like all your filters are gone basically, right?
Yeah.
And then the filters come back, then the depression hits, and you're amenable to treatment because you feel terrible. But when you're feeling great, you're like, you guys are just trying to bring me down. Let me celebrate and be happy and go dancing at 3 a.m, that kind of thing. Run for mayor.
Totally. It's like mania is like that, you're just all the way on, and I can't see it as any other way but like a high energy state in the brain. I've tried every other way to like think about it, but when you're in hypomania, I get this, I'm bipolar 2, and so you have this hypomania, which isn't quite full mania, but you get this kind of up state. And you could literally, you have such a flood of ideas, like this constant stream of ideas coming into your head. It's very hard not to share them because, you feel activated, you feel inspired, you feel like you want to, but to other people that can seem like overwhelming, going through those states. But I do think it's a high energy state in the brain, and depression is like this crash that comes where you get this very low energy state in the brain. And there's actually a lot of biochemical and brain imaging and other reasons to think this is the case. It's actually like the first ever psychiatrist who diagnosed bipolar disorder, Emil Kraepelin, in 1921. He published this book called Manic Depressive Insanity and Paranoia. And he defined in that book bipolar disorder as a separate condition to other mental health conditions. And he said in this condition that his exact words were, the conspicuous lack of energy is very notable in bipolar disorder when people are going through depression. And then he said with his patients with mania, he said they'll work all through the night, they'll be up all night dancing, working, doing things. And he said it's like the kind of surge of energy is very notable. And then his conclusion was, he said, in manic depressive insanity patients, marked disorders of metabolism must take place. This was in 1921. And
wow.
He was just observing his patients. And like you say, if you live with a family member who has this, it's really notable. Like in depression, they just might not leave the house or the room for weeks on end. And then when they're manic, they're just all go, and, up all night, often have insomnia and things like this. So it kind of helped me to understand these as energy disorders, because like you say, when you have, your family member acting strangely, it's so hard to interpret that because you know them as a whole human being and their personality, and you're trying to understand why they're acting this way. But if you just see it as like they're a car with the gas pedal jammed on all the way down, then it begins to kind of make more sense. It's like they can't help this. There's a biological kind of accelerator happening inside them. And this is,
and especially too, like if you think about it, it's like when they're manic and they only sleep 2 hours a night, like their brain's not recovering, and there's so much inflammation, and you're not getting good recovery, and then then all of a sudden you take your foot out and you slam on the brakes all of a sudden and get depressed and or out. Like when you start getting hypomanic, do you realize it, like, oh, something's off, or you don't even know until after, and you look back and say, what was I doing, like when I was doing crazy stuff 2 months ago?
Yeah, usually you don't know. I was fortunate in that I only ever had hypomania and not full-blown mania, where you end up in hospital and things get really bad. But I had hypomanias where, and I just generally used to just, I found kind of ways to channel it. Like I would listen to music, write music. I would write ideas down. I kind of found, I suppose, like healthy outlets for it. But yeah, it definitely feels like a high energy state. And then the depressions were just like, you can't move. It's hard to, I always try and describe it like, people think it's like, oh, you feel your mood go down or you feel a bit sad. But actually it's much more like being deprived of oxygen. Like your physiology is just not working correctly and you can't move or function in the same way. So I describe it almost as being like, more like mild oxygen deprivation. That's what it feels like. It's like you just can't quite catch your breath enough to function properly. And there's actually,
and then the mental functioning too, right? My mom would tell me like it would take her an hour to figure out what to wear to go to work. Like she would just be staring there, like no energy to like make a decision, or like you're almost helpless.
Yeah, totally. It's and it's hard because you see them so functional for periods, and then you see them just like go into the state, and it's like, how can this person who 1 minute was so functional and communicating be, unable to communicate, unable to leave the house? It's really a confusing illness for people. So yeah, I mean, like, so a lot of motivation comes from that. I really want to both get better treatments to people, but I also have a very I need to understand what the condition is. I need to understand what's happening physically in the brain that causes it. It's almost like it exists in the neurons that I use to think about the condition, like it's affected by that condition, and it makes me need to understand it in that way, and also to sort of like give explanations to families that are going through it, because I feel like what I said about the piano analogy with your brain function, it helped me understand my mother's illness, but I never found that for bipolar, like this kind of framework to understand it. And the energy one is the closest to being helpful, because it kind of gives you something you can do. It's like if someone, watching this as a family member, like going through this, just having some kind of grasp on what's happening can help you to work through it. So seeing kind of mania is that the brain is lighting up, in a high energy state. It can help you to understand what may be helpful and helping them to calm from that. And conversely, if they're in depression, like what could help them to restore their energy.
That's fascinating. Yeah. Tro, you want to jump in?
Yeah, I mean, I think like it's just I think the listener here, right? Like just to give them a little bit of guidance. This is like a scare. And Brian, I know your mom's dealt with this, and like I think the person listening often struggles with understanding how scary it can be when you start to lose touch with sort of reality. And when you hear bipolar, and the average person probably just thinks like mood swings, right? It's not mood swings. It's fundamentally, sort of disorganized thought patterns, maybe paranoia, excited thinking, lack of sleep. I mean, the whole life is like devastated for days of the person undergoing, and it's quite dangerous, right? This is a vulnerable time period where, you're moving from one thought pattern to the other, connecting dots where maybe they don't exist. And, you know, and then, and the people around you are terrified, right? They're absolutely like terrified. They don't know if you're going to become violent. They don't know if you're going to hurt yourself. They don't know if you're going to hurt somebody else. They don't know if you're going to, what's going to happen, and it's a period of just helplessness. I know both of you guys know this, and then there's other times where it's like long periods of just sadness and not lack of function. And one of the parts that kills me and one of the parts that makes me so excited to have you here is, for the long, and I don't mean to change things up here a little bit, but one of the parts that kills me is for years, people have just quote unquote, the medical profession has just managed symptoms. Like literally, and a lot of times they don't even do that. I had a patient recently in psychosis. I sent them to the hospital, hadn't slept in 5 days, completely out of touch with reality, right? Paranoid thinking, disorder thinking, sent them to the hospital. The ER doctor gave just like hypnotic medication,
Haldol.
knocked him out in the ER, said, gave him enough of a sleep. He took a nap, woke up, gave him enough sleep that he was saying, oh, I'm not going to hurt myself. And, he was able to answer a couple of questions and then discharged him. And this is like standard.
Yeah.
Right. And, it's just, I don't think people understand how desperately we need you to help figure out how to do more for people who have this. And I feel a little cheap talking about this. I mean, Brian, your mom, and I know, rest in peace, this is something you've dealt with like your whole life. And Dr. Campbell, I mean, this is near and dear to you. It's a desperate, desperate place. It is a scary time.
Yeah, it's just, and it's interesting. I'm wondering if you've looked at brain scan, because I always wondered this, but I don't know because I'm not in psychiatry or anything. But I always wonder if like it's almost like you're drunk, like almost like you're a drunk and manic and having a good old time, but you lose that frontal lobe. So I'm wondering if other parts of your brain start taking over because the energy overload, the other parts that aren't as good at communication skills or whatever are being taken over, because this whole flight of ideas fascinated me, because she would talk about like going to the store, then all of a sudden we're talking about Germany, and then we're talking about France, and then IQ testing is like, wait, this isn't the same sentence all run together. I'm like, wait a minute, I can't follow you. I have no idea where you're going with this. Like Robin Williams, there's like talking to Robin Williams when he's doing all of his characters, at some point you go, wow. No idea what you're talking about.
Yeah, so I mean, what you described is exactly right for bipolar. In brain imaging studies, there's a reduction in prefrontal cortex activity, the kind of control and executive function parts of the brain. But the other, people might call it some people call it the reptilian brain, the more survival centers like the amygdala can be firing on overdrive. So there's a kind of, this is quite well understood in the brain imaging literature that you get this prefrontal cortex inhibition, but then you have this kind of emotional center overdrive. And so you're not able to control your emotions and your behavior in the same way as you would in a healthy state. But your emotional centers and other parts of the brain can be really running in a kind of hypermetabolic state. To go back to what you were saying about the sedation and how they treat patients, like it's not very commonly recognized how deep this goes into the history of psychiatry. So like if you look at the very first people that developed antipsychotic medications, it was a guy called Henry Labouré. I've got his books here, and he wrote these books, and they're all like out of print now. But he was the first person to develop an antipsychotic. He took this medication that was a sedative, and he applied it to psychiatry. And if you read about what his thinking about how this worked, what his kind of framework for understanding this medication was, it was called chlorpromazine. He said it was a metabolic depressant. So the very first antipsychotic used in psychiatry, chlorpromazine, was described as a metabolic depressant. And if you look, Labourie's work, I've been translating it all from French recently, trying to understand what he was trying to do. And he basically said that these are metabolic dysregulations in the brain. He was like, Chris Palmer, but from, 100 years ago. And he was basically describing this state of hypermetabolism that happens in the brain in psychiatric conditions with mania and psychosis. And he said the brain gets locked in this state of hypermetabolism, and he was trying to find medications that turn down this hypermetabolic state. Nobody ever talks about this now. It's completely lost in history. But he was really the person who started the whole modern age of psychiatric treatment. And he said right at the beginning, these are hypermetabolic states in the brain. We're using these medications to bring them down. So he developed chlorpromazine, and he was actually an anaesthetist in the Navy. He was using these in surgeries, and he gave this thing called the lactic cocktail, which is a cocktail of drugs that would give anesthesia to patients so they could have operations. And he just took one component of that, this chlorpromazine, and put it in psychiatry. So like when you say sedating patients, this was at the very basis of mental health treatment, was giving metabolic suppressants to suppress hypermetabolic states in the brain. And this was the whole conceptualization of how treatment worked. And then from chlorpromazine, many other medications were iterated on and developed, but they all had this function of lowering metabolism. And the reason this came about was because in asylums at the time, what they would do is they put people in cold wraps. So they would wrap people in ice cold sheets. You can read a book by John Perry Baird describing this. He was a psychiatrist, but also someone living with bipolar disorder. And he describes this terrible process they would put people through in asylums throughout the 1800s, where they would wrap them in ice cold sheets. And they would do this to cool their body temperature. And the way they thought about this was that people were becoming hyper-metabolic, full of energy, and they were kind of trying to put them in a torpor-like state. They were trying to like reduce their metabolic function. And they would leave them for, like a day or 2 days in this cold wrap sheets. And the other treatment they would give was insulin shock therapy, where they would just inject them with insulin until they went unconscious. So it was a terrible thing to be in an asylum in the 1800s. You wouldn't want to be subjected to this. But Henry Labouré saw chlorpromazine as a more humane way of achieving the same effect by giving a metabolic suppressant that achieves. And he actually noticed this because when they were doing the cold wraps, he saw that chlorpromazine was reducing body temperature in his patients. So he said maybe chlorpromazine is achieving what 12 hours of a cold wrap could do with someone by giving them a medication. So like right at the beginning of psychiatry, this idea of giving these sedatives was a part of, kind of mainstream psychiatric practice, but this has been lost over the last kind of 100 years. So when you're talking about sedation, it's a very deep idea in psychiatry, the idea that these are hypermetabolic states and we need to sedate people down from them.
That's very interesting, because you look at all the psychiatric meds for schizophrenia or mania, and people get obese when they're on the medication. So maybe it's slowing their metabolic rate.
Yes. I think that's exactly what it is. I mean, like you see people go on these medications and they put on like 20 or 30 pounds of weight, and it's quite devastating, particularly for young people I speak to that go on this, because for their social life, their self-esteem at that age, to put on like a lot of weight very rapidly is very bad for them. But it's always been seen as like a pure side effect of the medication, not the primary mechanism of action. But to me, it's like staring you in the face. It's like these are metabolic. They're acting in a way to suppress metabolism so that the person can't go into these manic or psychotic states because the brain kind of can't ramp up into them. But then the downside of that is on your physical health, it's suppressing all of your metabolic function to the point where you can't operate and you put on lots of weight. So it's complex why this like split between mental and physical health happened, but that's always been the way psychiatry has operated since the age of psychopharmacology. Is you're kind of trading a bit of your physical health to maintain mental health. Whereas if you go before that to Laborie, Kreplin, and the very early kind of pioneers of psychiatry, they saw this quite differently.
Can we give a quick anecdote to support what you're saying here? That same patient I was talking about, describing sort of the terror of bipolar and mania, was admitted to the hospital and given antipsychotic treatment. And immediately, we had labs before he went to the hospital, and we had labs during the hospitalization, immediately developed dyslipidemia, right? Immediately developed 100-point increase in cholesterol, immediately, developed a higher blood sugar, and then went on to gain, 20 pounds as you described. And I'm talking about in the course of a 1-week hospitalization. After he was discharged, sent to a different hospital and admitted, he was able to sort of get rest and get sleep. So there's something there. If you look at things that cause metabolic dysfunction, B12 deficiency, a whole host of vitamin and nutrient
Vitamin D3.
Yeah, all these nutrient deficiencies that cause insulin resistance, right? Worsen psychiatric conditions. And if you look at the treatments, all the treatments for this psychiatric condition worsen, metabolic disease. So there's clearly some link there. Maybe mitochondria explains it all, but it certainly, the patterns are all there. I think sleep deprivation.
And so that's why it becomes not a leap to go to a ketogenic diet and you get a clean fuel source for your brain. And I would love to hear your take on that, like what you're seeing, because I have other ideas too. I'd love to just run by you. I'll make Tro a little crazy. Tro's jumping on my bandwagon a little bit more. But I think we're seeing a lot of different things going on. But I would love to hear your take on what you think, why we're seeing benefit from a ketogenic diet or cutting out processed foods in mental illness.
Yeah, so...
Well, I'm going to tack on one more, right? Is it mediated by the ketones or the gut microbiome or both?
Oh, that's a good one. So if I could tie together the... if you look at how people like Henley Laborie approached this, they were trying to suppress these hypermetabolic states in the brain. And one of the ways that he then tried to do this was to develop medications for this. And one of the medications they developed was called 4-hydroxybutyrate. And this was, in the kind of 50s, 1960s. And he was trying to make medications that would ameliorate this hypermetabolic state in the brain. And he literally made what he called a ketone body called 4-hydroxybutyrate. He said, I've developed a ketone body. It's not technically a ketone body in the scientific sense, but kind of pragmatically speaking, it was. And he started treating people with this, and he said that this was helping restore the kind of normal metabolism in the brain by turning down these hypermetabolic states. And basically, this is very, very close. It's like a chemical analog, actually, of beta-hydroxybutyrate. It's actually almost the same molecular structure. And the ketone body that we measure in our studies is beta-hydroxybutyrate, which is 3-hydroxybutyrate. And so there was attempts throughout psychiatry to stabilize these metabolic states in the brain, but none of them ever fully succeeded. There was always problems with the medication, there was side effects, there was things that went wrong. But going all the way back from the kind of early approaches of cold therapies, hydrotherapies, instant shock therapy, they were always trying to find ways to control, in my opinion, the metabolic state of the brain. And Laborie got very close. He literally developed 4-hydroxybutyrate, which is very, very close analog to beta-hydroxybutyrate, 3-hydroxybutyrate. But then it kind of got lost. There was a large push towards certain kinds of medications with certain explanations to do with neurotransmission of how they worked. And we never really got fully effective treatments. The attempted suicide rate for bipolar is still 1 in 3 or 2 in 3. And so we kind of got into this situation where we were trying to treat this with medications that we don't really fully understand how they work, and the suicide rates are remaining unacceptably high. But then there was a parallel development in epilepsy where they started testing ketogenic diets in the Mayo Clinic for epilepsy and seeing seizure reduction. And many of the medications that came from to bipolar came from epilepsy research. So valproate, lamotrigine, carbamazepine, these were all epilepsy medications. So this was the kind of second wave of metabolic research in neurological condition. And Russell Wilder at the Mayo Clinic developed this ketogenic diet for epilepsy. And they then had 13 RCTs, and it's had over 100 years of clinical use. But this whole time we've been treating bipolar patients with epilepsy medications and never making a potential connection to a ketogenic diet. So but this kind of came into the public mindset, like people like yourselves introducing this idea of ketogenic diet being a helpful metabolic intervention, and patients with bipolar inevitably, just by chance, started trying this to lose weight. I tried it to lose weight initially. This was my only motivation towards it, was to lose some weight, and I noticed my brain becoming clear for the first time. Like, my thoughts were clear. I was not having manic or depressive states, and I recognized something was important here, to the point where I realized that I'm going to spend the rest of my life trying to understand this, because it's the only thing that's helped me to feel normal. And then I looked online and tried to find out, are there any other bipolar patients experience this, and I found 176 at the time, just posting in weight loss forums saying that I've tried this weight loss intervention and my mood is like either completely stable or greatly improved. And I published this in BJ Psych Open, I think around 6 years ago or so, noting like how many patients were experiencing this. And then there was case studies appearing in the literature of ketogenic diets for bipolar disorder, people like Chris Palmer. And then eventually we realized this might actually be helpful, and we got funding to do a pilot study. And I'm going to come back to the what you asked about, how this might work. But essentially, we did this pilot study funded by the Bozuki Brain Research Fund to try and understand what was changing in the brain. So, I always had this feeling that these are kind of altered metabolic states in the brain. And in epilepsy, they've got this treatment that seems to stabilize brain function. And so we tested and we did brain imaging on 27 patients with bipolar disorder. 20 of them completed the trial. And the most notable effect of ketogenic diet we saw in brain imaging was a reduction of brain glutamate. So we saw 11 to 13% reductions of brain glutamate in our patients on a ketogenic diet. And glutamate has been a primary marker in epilepsy. It's considered like a core marker of epilepsy treatment. And it's also considered a marker of response to treatment if you see a reduction of glutamate. And we saw in 8 weeks on a ketogenic diet 11 to 13% reductions in brain glutamate in brain imaging in these bipolar patients. And many of them reported improvements in mood and energy and reductions in anxiety that were correlated to their ketone levels. So as their ketone levels went up, these mental health symptoms tended to go down. So I think that I think this was like the first sign we had of an energetic change in the brain. There was this change in glutamate metabolism in the brain occurring in these patients, and it seemed to be related to increased ketone levels. And so I think I think one of the primary mechanisms of action is this energetic change in the brain, stabilizing brain metabolism. But then there's some people who experience benefits on a longer timeline, like 2 or 3 months after starting the diet. You also see this in epilepsy. And I think that some of those might be microbiome related, like slower shifts that are happening in the body, like longer term mechanisms. So there's some people who respond very quickly, like within 3 days. That was my experience of like within a couple of weeks of starting this, I noticed a significant change in symptoms. But there's some people who have longer trajectories of responding to this, and maybe these are like microbiome related and have longer term effects. So I really do want to understand that. It's a really interesting question for research. So I think, to summarize, going from the early stages of psychiatry, they were trying to balance brain metabolism, and we kind of got a bit off track and went towards other forms of treatment. But then epilepsy maintained this kind of route towards ketosis and these kind of brain stabilization approaches, and now we're kind of rediscovering it in psychiatry, I think.
Yeah, it's amazing. And that's what Tro knows. I've been harping on the gut microbiome, because the more I look at it, the more fascinating I become, because you go, gosh, a lot of our neurotransmitters and these short chain fatty acids is really fascinating. They calm the brain, heal the gut lining, and these lipopolysaccharides are these toxins that leak across when we have a leaky gut. And you think, man, they increase our risk of atherosclerosis and all these things.
Yeah.
So you wonder how much is the ketogenic diet healing the gut too? It's like, I think we need to address both. Say, let's heal the gut. Let's get you on a good nutrition plan, take out the processed food and all the stuff that's screwing up the gut microbiome, and decreasing inflammation in the brain. I think there's so many fascinating areas, and I would love to hear your take on that. And then also, there was some talk a few months ago about lithium being somewhat helpful for preventing dementia. I don't know if you've seen it. That may have to do with brain metabolism also.
Yeah, I'm really interested in lithium. I have a paper in Nature Translational Psychiatry called Lithium and Insulin Signaling, and it just points out that most of the primary targets of lithium are parts of the insulin signaling network. And like, even the first descriptions of how lithium worked, like Peter Klein in 1996, he identified this target of lithium called GSK3, and he said lithium is acting like an insulin mimetic, like the biological effect it's having is like an insulin mimetic. So there's clear metabolic effects of lithium treatment. You mentioned sort of like the gut microbiome and neurotransmission, and I think these are really interesting areas for research. We haven't seen a lot of microbiome research in bipolar disorder and in the conditions that we're studying, schizophrenia, related to ketosis, and this could be one of the main mechanisms of action. But yeah, I think as well the kind of neurotransmitter explanation of mental health is something that I found difficult, because you're having such severe symptoms and such severe changes in your physiology, and you're told this is a neurochemical neurotransmitter imbalance, and it doesn't feel like that. It feels like you're driving down the highway and the car is filling up with smoke. There's like some major emergency happening with your physiology, and trying to fix neurotransmitters feels to me like adjusting the air conditioning in the car. It's like, maybe it's helping a little bit, but it's not really fixing the problem. And maybe the actual problem is that the engine is on fire, your metabolism is on fire, and then that causes all these downstream issues with neurotransmission and other things. But if you just fix the engine being on fire, you'd actually deal with all these other problems automatically, instead of just trying to twiddle with the air conditioning. And to me, that doesn't feel like I took SSRIs, and it never felt like a real fundamental fix for these conditions.
That's fascinating. It is so, all your insight is so great. And then, suffering from the condition, obviously you have a vested interest in these things. Are there certain things you do lifestyle wise that you say, if I start feeling a little hypomanic, is there something that you do, and like relaxation, breathing? Is there anything that you say, gosh, this seems to be able to hold this off for a bit or prevent it from happening?
Yeah, so there's many things that are helpful. For me, ketosis was the only one that gave me relief from the kind of physiological state of suffering that happened with bipolar, especially the kind of deep depressions. Ketosis was the only thing that alleviated it. It was almost like, I described being deprived of oxygen and then being given an oxygen mask. That was what ketosis felt like to me. It was like I've not been breathing fully, and for the first time I'm taking full breaths. So it was really the main thing that gave me any relief from symptoms. So I kind of really rely heavily on that. And but there's other things that are complementary, like sleep and circadian rhythms are important as well. Like having a regular sleep schedule. All these things also help regulate metabolism. So I try to combine them: exercise, sleep, and diet.
Ben Bigman, that's what he says. Go ahead, Tro. Sorry. But Tro, before you said that, I was just thinking, because this was interesting, Tro. I don't know if you remember, because I remember at the time thinking, oh, don't say it on our podcast, but we had a guest who was struggled with bipolar and major depression. You'll know who I'm talking about. He said he would just his treatment, he would go out in the middle of the summer and he wore a bunch of heavy clothes, like it was like winter time, run in the mountains. And he said he would go to almost exhaustion. He said, my depression, anxiety, everything got better for a month after that, 6 weeks. And it was like, then you start looking at these heat shock proteins and you go, gosh, maybe he was self-treating, like just figure out, you know what I'm talking about, Tro?
No, I know who you're talking about. I think if you actually look at the data, there's a lot of like hot yoga, sauna that benefits on, I'm curious, Dr. Campbell, do you do anything like, do you do intent,
Like
I
cold
know,
plunges,
yeah, I know Matt
sauna, anything like that.
Bazzucchi. I know Matt has talked about how exercise is important is his in his regimen. So I'm just curious, can you discuss your regimen?
Yeah, so we're kind of always cold in Scotland, so we're like a constant cold therapy experiment, and many people do like cold plunge, cold swimming, um, and I guess the like framework that I think about these kind of things is through like an evolutionary lens. So, humans for most of our evolutionary history were exposed to like more higher extremes of heat and cold throughout the year. In the winter, obviously, you had much more cold exposure and vice versa in the summer. And we're kind of isolated from these with like the constant air conditioning and temperature management of the modern environment. So it's not kind of fully surprising to me that like engaging with some of these deep evolutionary adaptations could be helpful for a mental health condition. And so I kind of think of all the things I try through this evolutionary lens. So heat adaptation is very helpful for your metabolic function. But also ketosis was a part of these kind of evolutionary states that we experienced throughout like most of our history. So, most animals and humans were going through periods of ketosis, periods of heat and cold, constantly changing their metabolic function to suit the environment. And so I think when you restore these signals to the human body, it can help regulate your metabolism. Light would be another one. So I tend to get up in the morning and try to get very early light exposure. I try to get some cold exposure. I try to go through periods of ketosis, and I try to eat a kind of diet like pre-agricultural revolution diet, not eating wheat, not eating processed foods. And all these things I feel give you signals back from our kind of evolutionary history that are helpful for our metabolism. So yeah, I'm always trying to engage with light and heat, exercise, and periods of ketosis to manage bipolar. And I think also, if you're thinking about a kind of evolutionary framework for mental health, there was the seasonal variation bipolar. In the spring, you get mania, like I mentioned. In the winter, you get depression. And you see this in the natural world, like animals going through these seasonal cycles of hypermetabolic states in the spring and metabolic depression in the winter. There's some really interesting analogies here with bipolar. So if you look at a systematic review of hospitalizations in bipolar, there's 2 times of year when people become manic. It's the spring and the autumn. And it's specifically, if you look at the graphs, it happens around the spring equinox and the autumn equinox. And these are times of year when the light is changing very rapidly and animals are engaging in hypermetabolic behaviors like migration, for example. And they're engaging with like very high energy states to have these survival behaviors of hunting, migration, these sorts of things. And then in the winter, there's obviously the clear analogy of like torpor in animals, like reducing their metabolic rate right down into kind of hibernation states and conserving energy. And I think these resonate with people with bipolar when you experience this seasonal variation. They're not like perfect analogies, but they're helpful, I think, in thinking about what happens. Perhaps we're going to these like hypermetabolic states in the spring and metabolic depression states in the winter. So I think I have a kind of like I try to engage with signals to my body that give me a sense of the environment through things that we were exposed to through our evolutionary history.
No, like getting outside, not being inside all day, exposed to natural lights and going for walks and seeing the birds and all that kind of stuff. I think there's so much to that we just don't appreciate also. But it's really fascinating. So do you think just in your studies that the root cause of all these mental illness that we're seeing with bipolar depression, anxiety, schizophrenia, it's going to come down to a metabolic issue
Yeah, I think
and just different expressions of that.
yeah, I think from the earliest observations of psychiatrists, people who develop pharmacology, and now in metabolic psychiatry, this has always been a perspective of what caused these conditions was metabolic dysregulation in the brain. And we just didn't know how to treat it. But for the first time, we're seeing indications that ketosis could be helpful for these conditions. And I think that, you know, the reason this might happen is, so if you think about depression, for example, if you think about metabolic depression in the winter, what many things in nature are doing is trying to conserve energy. They're trying to conserve energy and reduce their metabolic function. And the natural evolutionary adaptation for that is ketosis. You're turning down your glucose metabolism and you're turning up your ketone metabolism to ride you through these states of metabolic depression. But what happens if you get someone who's heavily suppressing their metabolism, but they're not introducing ketosis, and they're continuing to push carbs into a system that's trying to conserve energy? You know, it's like trying to run your car with the brake and the accelerator on at the same time. You get stuck in this depression, but you're also not fully rested. So I think that this kind of evolutionary mismatch is partly what's happening. And I mentioned Henry Laborie, who developed chlorpromazine and the early antipsychotics. He actually called his treatments artificial hibernation. That was the name he gave to them, because he said what we're trying to achieve here is almost like a hibernation type state. When someone's manic, you're trying to bring them down from that and suppress their metabolism. So I think that there's a kind of evolutionary mismatch happening here with constant exposure to artificial light, artificial food, and it just sends these incongruous signals to the body, and because of that you can get into these very deep metabolic depression, very high hypermetabolic states, and this is at the root of things like bipolar, schizophrenia, some of the psychiatric conditions. I have a paper in Nature Molecular Psychiatry called Metabolic Plasticity, making an argument for this. It lays out the kind of seasonality and the seasonal changes in metabolism and how they might relate to these symptoms.
So of all the work you've done, what are you most proud of? What study that you've done that you say, wow, this is going to make a difference, or we've learned a lot from this? What do you think is if you have to grab one or two that really impacted you?
I think the pilot study of ketogenic diet for bipolar is most proud of, because for many, many years we were trying to get funding to study this, and turned down from almost every grant, every fellowship application. I had to actually work a day job, and I would work till 2 a.m. to try and do this research, gathering patient perspectives, doing interviews, and yeah, it was really difficult to get anyone to pay attention to this for a long time. But actually, at one point, I wouldn't say I would have given up. I wouldn't, but I just didn't see any way forward with it, and I made a YouTube video. It's on an old channel I've called Keto Bipolar. It's the only video on that channel, and I made a Twitter account and I posted it because I was like, well, maybe like Laborie and other people in the past, this will never get picked up and researched properly, but I need to leave some record of what I've learned here about this. And so I put up this 45-minute YouTube video, and it was found by Chris Palmer. It's the very first post I ever put on Twitter, because I made the Twitter account just to try and get out there to someone. And I didn't realize that Chris Palmer, he picked this up and he found it, sent it to on his Twitter to all his followers, and Jan Bazuki, who is a philanthropist in America, saw that video, and she sent me an email and said, my son had the same experience. He went into ketosis, his bipolar symptoms went away, we have to talk. And so we started talking about this, and me and Matt started this Keto Bipolar podcast, interviewing patients with bipolar disorder, doing a ketogenic diet. And then this led to doing a pilot study. I think we connected 24 testimonials from people. And I was showing these to scientists and saying, we've got to pay attention to this. And so eventually the Bazukis funded our pilot study at Edinburgh with Professor Daniel Smith, who I work with, and my father, Harry Campbell, who'd been through this journey of bipolar with me. We collaborated on this study to learn about it. And yeah, we found really promising indications. I've always tried to be understated with a pilot study. What you can say from it is a very small sample size, but we saw such clear indications that this is worth exploring more. We now are doing much larger research projects to try and get a better picture of it. But yeah, the pilot study, I just feel there was like times during that period where I just felt like I can't. I was working a day job and I was working until 2 or 3 in the morning every night trying to like get attention for this, and I used to just like sit on the sofa and like be very close to not be able to continue with it because I was so exhausted from the process. But just at that point, when it was getting quite hard, the Bazookies came in and started funding research, and it was really that then the whole field started to accelerate. So I think that was the genesis of it, but it was very hard to get that pilot study done. So.
Wow, that's it's just amazing. I thank you for your dedication. It's just you having a passion like that. I think so many times the problem is we have scientists who are funded by the wrong people and they find what they want you to find. And so gosh, having like the Bazooki Foundation, how huge that is. And especially for me and Tro, because it's so great because I'm not Tro's a researcher more than me, but it's like when you see something clinically, you go, wow, this is wild. Like when you see something, I'm seeing people's like they came off insulin, came off diabetes, they lost 40 pounds. They go, best thing is my mood got better. That is the most important thing. And one after another saying the same thing, and so when you see it, you go, wow. So we observed it and we go, we're seeing this, and people go, you guys are charlatans, you're crazy, it has nothing to do with this. Like, we're seeing it. I don't know what to tell you, that either our patients are all actors or they just want to like impress us, or they're happy, or they're less agitated.
Yeah, like I used to gather these testimonials. I used to go on Reddit and copy and paste them all and put them in a document, and I'd like print it off and go to around universities and speak to psychiatry professors and say, like, isn't this remarkable what people are describing? And like literally everyone, didn't want to.
It's anecdotal, doesn't mean anything.
Yeah, for sure. And I get that. I do genuinely get that. But I just felt like, because I'd personally experienced it, I had another level of conviction about it. And eventually we met Daniel Smith, who's at Glasgow, and he was really listening and supportive of this. And that was what helped it to move into like proper kind of academic research. And I really like, it was a journey with my father was someone who worked in developing countries his whole life with like complex illnesses. He was in global health. And he's seen like a lot of very bad situations, and he kind of was always dedicated to trying things that were new and could help relieve suffering of people. And so he helped me through these depressions and manias my whole life to get to that stage. And so I kind of credit him as one of the people who started this line of research for us, because I wouldn't be alive and sitting if it wasn't for him as well. So between him and Daniel Smith starting it, we kind of, and now we have a hub for metabolic psychiatry in Edinburgh. We put in an application to the government funding over here, which is called the UCARA MRC. It's like the most competitive funding scheme in the UK, and basically every university gets one application, and then all those applications compete against all the other universities for like 5 awards, and so it's just crazy competitive. But we went in for it, and I just recorded like videos with lots of patients who are having this experience, and I made like animations of them. I made these little films, and I started showing these in these meetings, and you hardly ever hear people with mental health conditions like this getting better. And I think it sent a signal, because it was like these people are clearly benefiting from this in a way that we haven't seen before, and I think that helped towards getting. So we got the centre funded for 5 years across 5 different universities in the UK to study this. So yeah, it came from those patient experiences, like in sharing this whole support for this in the academic world in the UK.
Have you come across anything else like micronutrients helping, or like creatine? They talk about that for helping with dementia and Parkinson's, maybe. Anything else like that you see that like there's, I'm fascinated. I just interviewed a lady talking about autism, and she was saying 37% of autism can be reversed through lifestyle changes and stress management, all these things. And I didn't realize that. I think the number 2 cause of death in autism is suicide. And in bipolar, it's markedly elevated also. So I'm wondering if there's any other, like you're going to do a clean, cut out the processed food, eat a ketogenic diet if you can. And then are there other things we could add in that might be helpful, like vitamin D3 or zinc or anything else, that micronutrients that may affect metabolic rate of the brain?
Yeah, so one of the most interesting ones you mentioned was like for Alzheimer's, lithium orotate. And there was that recent study showing that this might be preventative for Alzheimer's, and that sort of the mice they studied who developed Alzheimer's. I'm not a huge fan of like animal studies, but the this is what they found, that the ones who were depleted of lithium were at more higher risk of Alzheimer's. And I think that there was much higher concentrations of all these minerals and electrolytes in the environment and in our water supply. Again, like an evolutionary kind of thing, where for most of the evolution of life, we're exposed to these minerals through the water supply, and then we just have very low levels of them now, which is why we're obviously buying mineral water and things like this. But we don't really know what happens when you deplete the human body of these like minerals. Magnesium is very important. Lithium was in a lot of water supplies worldwide for long periods of history, and then it's kind of no longer present. So we don't really know what happens when you just remove these things that the body is co-adapted to. And I think lithium is one of the most interesting ones, because it's now like a mainstream treatment for bipolar. But you can also get these supplemental forms that are lower dose, like lithium orotate, and it's increasingly looking like they're helpful for Alzheimer's and brain conditions. So lithium orotate is one of the ones I've been quite interested in. And there's some research on this in bipolar that's looking interesting. We don't really know yet whether it can be like a therapeutic, but it's definitely one of the most interesting ones to me.
Wow, thank you so much. Gosh, your knowledge base is so amazing. We appreciate you, educating us and our audience for sure.
Oh, it's great. It's great chat. These are my favorite topics, so I could chat forever.
How do people find you? How do people reach you? How do people support your work?
So I have a podcast with Matt Bazzucchi called Keto Bipolar, and I'm on X as Iain Campbell, Ph.D. IAIN.
Wow, Keto Bipolar, that's awesome. Yeah, and they can see that on YouTube and wherever else, like listen to it on Spotify.
Yeah, this was a podcast that I started with Matt to raise awareness about these patients having these kind of effects of ketosis on bipolar symptoms. So we've interviewed something like 24 patients, but there's probably hundreds now, if not thousands. I'd say certainly thousands using this, and you can find many patient advocates online sharing their experience, like Hannah Warren from Metabolic Mind, and Oliver Seligman, who was a participant in our pilot study. Lots of people documenting their experience with it.
Yeah, and if you're listening, go to Metabolic Mind. I think it's metabolicmind.org, or is it .com? I can't remember. Either one, find it. Metabolic Mind, put it in there. And so many great people, so much great research is being done. They're really supporting your work and a lot of people's work to get the message out. It's so hard if you don't have pharma money to do these studies. And so to be able to say, gosh, we can do it through lifestyle and, stress management, all these things that we kind of are common sense. We know stress is a killer, but, figuring out how to find our peace and get out in the sun and go for little walks and, all these things Tro and I are talking about, it's so great to have a scientist here confirming it's helped you and you're helping other people through your, you wonder why we get these things, and, you're being used to help the world. It's amazing.
Thank you. Well, I just want to be useful like that. I feel like the thing you experience with bipolar is going through long periods of your life not being useful for anything, like going through depressions and manias. You feel like, I just want to do something like basic to contribute to the world. Like I really want to have a family or contribute in just like simple ways, and so it feels good to be useful if you're bipolar, because you feel like you're kind of not just surviving but trying to contribute something back, and so I feel good if people are benefiting from this information and research.
Thank you again. Thanks for coming on.
Yeah, thanks for everything. And when you go your new paper, you let us know. We'll have you on every time you have an open invite, because this is critically important. We're seeing an uptick of mental illness. Like, it's incredible to me. I can't imagine what we're seeing and how many people are going to be affected, and families affected, and society affected. So your work is critically important. So thank you for all those sleepless nights and working hard and thinking and perseverance, really, like going through that, and having bipolar on top of it doesn't make it easier, but you're being used in a way that's amazing. So thank you so much for taking the time to join us.
Thank you. I appreciate you guys, and thank you for trying to help people take the kind of hard but sustainable route to like improving their health, because I think that's something I really appreciate a lot of people looking for quick fixes and how to take a injection or something to fix their metabolic health. And the only way I see for mental health is the long term, like proper, sustainable approaches to these things. So I very much appreciate your work advocating for that.
Yeah, we're trying. We're trying. It's been, yeah, I was just talking to Jason Fung, and it's been 7 years, Brian, 7 years to the day that we've been doing this podcast.
Wow.
We've been censored. We've been told, we were told we were crazy when we said mental health has to do with diet. We were told we were crazy.
Addiction, like so many things. And you go, we're seeing it. Like, come look at
Yeah.
our records. It's there if you want them. Yeah. So it's amazing.
It's good to have the research community, academic community start to catch up, and to have you be such a strong advocate for a ketogenic diet and improving nutrition, improving lifestyle. Uh, it is the only sustainable way forward. We can't just give people disastrous school lunches and then pick up the pieces with pharmacotherapy. That's just not an appropriate way to have a healthcare system. So I'm excited for everything you're doing and everything Brian has been talking about for years and everything you've been working on for years and everybody you said, Chris Palmer, Georgia Eid, everybody. It's just an exciting time to be in this space, and hopefully we can make a lasting effect for the next 30 or 50 years in medicine where we'll reverse the tide of this mental health crisis and this metabolic health crisis and the diabetes, obesity crises we've seen. So awesome, man. Just so humbled and honored to have you here. Always a pleasure to chit chat with Brian and you.
He stayed up late for us too. Yeah. So I appreciate you. I appreciate you meeting us late on your time. I know. So,
Nice.
and
Yeah,
everyone,
get
this
to sleep.
is
Yeah,
so
definitely
important.
get to
Please
sleep.
share this with your friends and family, people struggling with mental illness. So we have hope. Just got to make some changes, get out in the sun, enjoy life. It's so hard when you're down. So please share this with people.
Thank you. It's yeah, and I think as well the thing I really appreciate about you had a publication about your health program, and you can see that these are like really sustainably thriving individuals, and I feel like you lose a lot if you just take the shortcut of having an injection or something to manage your metabolic health. You're kind of outsourcing a big part of your agency to like an industry instead of taking your ownership of something that could improve not just your health but your character, your discipline, your feeling of kind of agency in the world. And I feel like you lose a lot of these things when you just outsource solutions to external kind of solutions, and then these kind of metabolic solutions. When I see people in our trial, that a great example being Oliver Seligman, he has a blog called Thriving with Bipolar, and I saw him at a conference today. He was a patient on our pilot study, and this is someone who's thriving, who's well, who's healthy, who's not only like thriving in their physical health now, but also in their work and in their career, in their family. And I'm like, I want to see people respond on all those levels, not just like have a weight loss and then carry on, but I love seeing people who are kind of thriving on so many levels of life like that. And I think the things you're suggesting and proposing for metabolic health are what lead to that.
Yeah, I mean, it certainly pharmacotherapy is a bridge only, right? And it's for select few, I think it's a lifelong it's a lifelong issue, right? Everybody's unique, but yeah, how can we strengthen each other? How can we lift each other up? Mark Cucuzella says it the best. How do we pick people up out of the gutter and bring them up? I think
Yeah.
that's the key, and that's where medicine always was. And honestly, it's more effective than many drugs we have, right? Just actually caring, giving a crap, and lifting people up, and focusing on some of the pillars that we all know are effective. That's what our evidence is showing. We have evidence coming out that's going to show a 45% 10-year and a 30-year reduction in cardiovascular risk, right? Including CHF risk, stroke risk, and heart risk. We're going to have this data, right? And we have data, showing cholesterol reductions of 500 points. We put that data out. We have, data on food addiction, binge eating resolving. We have data on, diabetes reversing and weight, 43 pounds weight loss at 12 months, right? Which is just astounding. Now, does that mean like we don't use medications? No. You know, we work with this company right now, new company we started with. We showed them a list of all the medications we stopped. We stopped like 100 medications. We started 12, right? So, but the idea is here, you know, can we do things that are appropriate and sustainable?
Well, and I think also we could talk all day unless we have publications like what your work is doing. If I have someone with bipolar, I go, here's the data. Here, look at these studies, and do you want to do this? And then at least it's credibility. Instead of saying, yeah, I do it all the time with my patients. Like, okay, like where's the proof, right? So having publications of studies and data, but Tro, the sad part is no matter how much you publish, there's gonna be people that are never gonna like it. They don't like the study. They don't like the way it's done. They don't like something about it, so they just throw it out rather than say, "Let's look at that and consider." Like what Iain's saying is like going to all these places and look at all these testimonies of people who got better, and they go, "Yeah, not interested." It's just that's the state of medicine right now, and unfortunately, it's like they'll keep doing what's not working rather than saying, "Wait a minute, maybe let's try what these guys are talking about and see what happens." And then once they see it, they can't unsee it. And that's the miracle of what you're doing and like how we all work together. Because, I don't go a day without talking about the work of Ben Bickman and what he's done in his lab and show people graphs that he did. If I don't have that tool, I can't explain it to him very well. So the work that everyone's doing in the labs and clinical research is so critical to moving medicine forward. And I think a lot of people now out there get it. They're looking and saying, I don't want just a pharma solution anymore. I want to make some changes.
Yeah, it's like I think people are waking up to this, and just in the kind of podcast world and the kind of even in the academic kind of spheres, they're no longer kind of buying the simple explanations for these things. They want to really understand what's happening, and in mental health, that's definitely been, I think, this kind of neurotransmission paradigm for understanding it, and we're realizing that's not the full story, and we're trying to find like more holistic approaches and more effective approaches. But as you say, like there is a real positive place for interaction between the medications and these treatments, and people, like I say, these reduce hypermetabolic states in the brain. And for someone who's manic and going into hospital or psychotic, that is life-saving. But as a long-term management strategy, we need things that don't sacrifice physical health for the kind of mental health improvements, and that's where I'm most excited about, is kind of long-term sustainable approaches to these treatments. And yeah, I think people are waking up to this being important.
Amen.
Yeah, I think I'm so thankful for all the work you're doing, all the work from the Bazookies, and the philanthropy and the leadership they've brought to this space. And I'm thankful for Jason Fung. I'm thankful for Brian. And, guys, if you have a mental health issue, somebody in the family with bipolar, depression, anxiety, please go visit Dr. Campbell's work and visit Metabolic Mind.
Yeah, and we'll make sure we have links to all your work there. Whatever you want to send us, Tro, we'll get that, put it in so people can click on it, go read the study for themselves and see what you're doing and watch your videos, the YouTube video. So yeah, and your podcast, obviously. Tell people one more time on the way out what the name of your podcast is.
Keto Bipolar on YouTube. Interviews with patients using a ketogenic diet.
Awesome. Thanks for bringing hope. We appreciate you, Doc.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.